I would like to thank Dr. Sharda Jain ma'am for motivating me to go in the field of embryology, and now it's my passion. I'm going to talk about a very important but very less talked about topic today. And believe me, it could be game changer if you pay attention to this topic for all people who are practicing fertility. So, as my previous speakers also pointed out, globally over 180 million people are struggling with infertility that compromises 15% of the population worldwide, and male factor accounts for 50% cases. A major development in the treatment of male factor came when the ICSI was introduced in 1992, around 3 decades ago. But, unfortunately, the ART results are still just at the success rate is still just 40%. It is static. What could the possible reason? Because even ICSI does not rule out etiology of male factor. So probably now is the time when we should focus on this point, then why even ICSI is not able to take care of the problem? What is there? Is there something macroscopic which you are not able to address? Probably yes. So generally, male fertility is assessed using semen analysis using WHO criteria, which include volume, number of sperms, sperm concentration, motility, and morphology. You all will agree with me, it is that conventional sperm motility and morphology is observer dependent. And it cannot represent the fertility of the sperm. So what do we do? What do we do? We need to find out a parameter which can actually tell us whether this sperm will be able to fertilize the egg or not, and whether this sperm will be able to produce a good quality embryo or not. Now here comes the importance of DNA fragmentation. So what exactly is DNA fragmentation? In a very simple word, when the sperm DNA is fragmented. It represents single-stranded or double-stranded breaks in the genome of spermatozoa. Because the mature male spermatozoa lacks the ability to repair those defects, these breaks tend to persist and can negatively impact male reproductive potential and the outcome. So why are we discussing DNA fragmentation here today? Because the partners of men with higher the DNA fragmentation, they are less likely to conceive naturally. Elevated DNA fragmentation is associated with the significant increased risk of recurrent pregnancy loss. It can even affect the outcome of ART. High DFI value have been found to impact pregnancy negatively in IUI cases, and not only that, it also lowers the pregnancy rate and miscarriage rate in IVF and ICSI cases. Though a recent study published in 2025 January indicates that there is no difference in pregnancy rate and fertilization rate and clinical pregnancy rate, whether we use fragmented or non-fragmented DNA, but there is significant impact on miscarriage rate, and it also leads to low birth weight babies. Now, what is this concept of dangerous father? It's a very well-known concept, and it highlights the importance of preeclampsia and importance of male factor. So, underlying cause of preeclampsia has long been recognized due to paternal HLA or because of seminal-free cytokines. It is well known that they create an abnormal maternal immune response leading to defective placentation, leading to low birth weight babies, preeclampsia, and all these aspects. So this study published by Stenquist et al. In January 2025 in the Journal of Fertility and Sterility, they talk about odd ratio of developing preeclampsia in high DFI cohort. It is particularly increased in the IVF group, but not in the ICSI group. So what was the reason? Because what we do in IVF, we put just a lot of sperms, and the oocyte is cohabitating with these fragmented sperms, which can impact embryo quality and ultimately lead to the development of preeclampsia in these patients. So after knowing all that, are we going to rely only on semen analysis, or are we going to add DNA fragmentation? Let us see, what does this study say? This study published in 2023 analyzed 182 men. They compared normal semen analysis, DFI, and both together. And let us see what were the results. All the subjects had a mean DFI of 15.3%. DFI increased with age. But in contrast, motility and morphology also decreased as the DFI increased. Patients who satisfied the WHO criteria in terms of concentration, total sperm count, motility had a significantly lower DFI than compared to those who did not satisfy WHO normal criteria. So the conclusion is that when the DFI is very high, like more than 30%, it caused a low blastocyst development rate, following even ICSI. Male infertility due to DFI should be suspected when IVF results are poor despite normal semen findings, based on the WHO criteria. The sperm chromatin dispersion test may more accurately evaluate the correlation between IVF clinical outcome and male infertility. So, I think this is a very important test which all of us should understand. Now, why does this DNA fragmentation happen? So there are three mechanisms. First is abortive apoptosis. That means the spermatozoa destined for apoptosis, they fail to complete the process and they persist in the reproductive tract, and this leads to increased DNA fragmentation, which is probably due to the action of endonuclease. Then there's defective chromatin maturation. While the maturation process, when the DNA is supposed to undergo compaction, that time they develop breaks and they do persist. As I told you, the mature spermatozoa, they're not capable of repairing those defects and they still persist. And third thing is, we all know it is oxidative stress, where ROS can directly induce DNA breaks in the testes or when the spermatozoa travel along the ejaculatory duct. So damage to sperm DNA can occur within the testis, during passage through the ejaculatory duct, or even in the lab when we are preparing the semen sample, or even during cryopreservation. And these are the common factors like infection in the semen, neoplasia, smoking, aging, chemotherapy, radiotherapy. These are all the factors which can lead to sperm DNA damage. Now, how do we assess sperm DNA damage? There are two tests. One is direct assessment, one is indirect assessment. This is just like HPV DNA and LBC. In HPV DNA, when we do HPV DNA, we actually assess whether DNA is present or not. So in direct test, we actually assess the DNA, whether it's actually there or not. But in indirect tests, which we normally do in the labs, we actually assess the effect of DNA damage on the sperm. And how does it look like? So in this test, we take a fresh semen sample, fix the sample, and then analyze around 200 spermatozoa. With a normal when there's a normal spermatozoa, it will show something like this, a halo around the normal, around the sperm head. That suggests intact DNA. But when DNA is fragmented, they will look like a pinhead. So you actually calculate 200 sperms and then get the percentage, and this is what is DFI, which is usually done in the labs. So now, once we know there's a damage, what to do? So there are lifestyle changes one can do. Environmental factors should be removed, varicocele corrected, leukocytes corrected, and obviously we can put the patient on antioxidant to get rid of this thing and to probably decrease the DFI. Now, the biggest dilemma of infertility expert, what to choose? Can we do IUI in these patients? Yes, we can. We can. But the preparation technique is different. How about IVF and ICSI? We'll see in the next slide. So here I'm talking about, I think the text is not very clear, I'll just speak it out. So the tips for semen preparation in high DFI cases are that keep the abstinence period small. Even 1 day abstinence will do, or even the few hours will do, no problem. Patient should be instructed to deliver the specimen just before the performing ART. Sample should be processed as soon as possible, and in no way it should be kept after processing, should not be kept beyond 4 hours. Ideal gap is 1 hour. We normally use SWAP or this double density preparation for semen preparation, but for these cases, the high DFI, microfluidics is a better option. I will just share a video of the technique which I'm using in my lab. So this is a device. This looks like a dish with a filter. You put 1 cc of semen, liquefied semen in the base. Then you put this filter, which has got small micropores. They are around 10 micron. Yeah, so it is fixed like in this groove, and then you take 0.9 cc of pre-warm media, any media whichever you are using in the lab, just put it over the filter in the groove which is meant for the media, and keep the dish in the incubator for 30 minutes. At the end of 30 minutes, just take out the dish, aspirate 0.5 cc this media which has motile sperms, and you are ready for your IUI. So this is called, this uses the principle of microfluidics, and this is a very simple technique, no expertise needed. Now, you can ask me, okay, the only thing is that this is a very expensive device. Each device will cost us around 3,500 rupees, and it is one-time use. So that's the only, catch. You can ask me, why not a normal swim up? This uses the principle of swim up, right? We are putting swim up. What do we do? Put the semen in the base, we put media up, and sperm swim up. So the same thing we are doing it here. So what is the difference? Because we are applying a filter over here, you can even use thick samples, viscous samples, which we cannot use in the direct swim up method. So that is the advantage, because this dish can be used both for normal and abnormal samples. And I have used this dish in something like 5 million count, and it gives you good result. Of course, for ICSI, you cannot use the 5 million for IUI. So when it comes to IVF ICSI, which one you are going to choose? IVF? No. Why? Because we just learned that in IVF there's exposure of a lot of spermatozoa to the oocyte, leading to poor quality oocyte. Then answer is ICSI. And what if the ICSI fails? Testicular sperms? Yes. Why? Because the sperm DNA damage is reported to be higher in ejaculated sperm, because during transit the damage increases more because of leukocytes, immature sperms, and dysfunctional mitochondrial mechanism. And also, in the various studies have proven that DNA fragmentation is lower in testicular sperm, and it also leads to higher pregnancy rate, 44% as compared to ejaculated sperm, which is only 23%. So you can, this more or less 1.5 times the difference. Yes, the birth rate was significantly lower, and we know the reason for that. So some frequently asked questions about DNA fragmentation. Should DFI be done if semen analysis is normal? So the standard for normal values in semen analysis, they do not reflect average value. Mind you, they are instead using the bottom 5% at a cutoff. That means this is the bare minimum. We call that less than 50 million. Okay, this is low count, but that's bare minimum. And also the DNA fragmentation test, they measures the quality of the sperm as a DNA package carrier, and therefore it is more significant. To understand this, let us understand a clinical scenario. A patient 37 years old, husband 39 years, comes to me, married 12 years back. She's a case of known PCO. Now, go through the history. She has 4 failed IUI. However, 2 spontaneous conception, both missed abortion at 5 to 6 weeks. 2 failed IVF at Bournehall Clinic, both blastocyst transfer, frozen embryo transfer, and failed. So when we have look at this kind of history, we start analyzing what could the possible reason. So she was carrying a beautiful embryology record, and it showed that those people retrieved 26 oocytes, out of which 16 were mature. Okay, you will think maybe she's a PCO, maybe may not be good quality, it's fine. All ICSI, all fertilized, all cleaved. They got only 3 embryos on day 3. I mean, they froze 3 embryos on day 3 and allowed rest of the embryos to cleave, culture further. And at the end of day 5, what they are getting, just 2 blastocysts. So out of 13 left embryos, they are getting just 2 blastocysts. So you should be alert. There is some problem, probably some problem with the male factor. Now let's have a let's see the semen analysis. What does it say? So now this patient is planned for the 2nd cycle. AMH is 12, AFC is 30, BMI is 28. Semen analysis fantastic. 2 cc, viscous, 40 million, except viscosity. You look at the other parameters, 40 million per ml, good count. 50% motility, 30% rapidly progressive. Pulses are less than 1 million. DFI is 25, borderline, yes, yeah, we have to think about DFI. So she was given antagonist protocol, but yeah, mind you, because DFI was borderline, I didn't, I could not think about talking about testicular sperm at this point. So I thought, let me take her for a routine cycle. So she was given antagonist protocol. Again, we found 26 oocytes. But yes, one thing I had discussed with the couple earlier, see, I have a doubt about the male factor, but since testicular sperm is an invasive process, if I get a lot of oocytes, I may fertilize few with the donor oocyte. This story is around 7-8 years back when these laws were not in force. Now we cannot use 2 semen together. So that was 7-8 years back. So the couple agreed to it, okay, you can use few oocytes for the donor semen. So we did the fertilization. 20 out of 26 oocytes, 20 were taken for the self semen, 5 were taken with the donor semen, and out of 21 in self, 11 fertilized. In donor, all fertilized. I was able to freeze good quality, 10 good quality embryos on day 3 for the self and all, and 3 for the, all 5 for the donor semen. Yeah, at this point, couple did not want PGT. So we just froze whatever we had. First is FET cycle was planned. I thought 6 day 3 embryos because she had a previous history of forming poor blastocysts. So I actually thought 2 leaves, thought 6 embryos, and you won't believe no blastocysts on day 5 out of 6. All the embryos, they were arrested at the compaction state. ET was cancelled, couple was distraught. They did not come to me for 1 year. In the meantime, she conceived spontaneously, again had a miscarriage. And POC for microarray was normal. Now what do we do? So when they came for the second FET cycle, that time she was already 40 years, husband was 42. They said, ma'am, no more trials, we'll go ahead with the donor sperm. So I transferred the embryos which had her own eggs and the donor sperm. She conceived. It was a twin pregnancy. One twin vanished at 6 weeks, other one progressed, and then she delivered a healthy male baby. So the take-home message is that if the blastocyst rate is poor, don't blame your embryologist. Think about DFI and TISA, even with the normal semen parameter. You know, in this case, semen if you look at the parameter, say, oh, ye to bilkul normal hai. There is no need for TISA, there is no need for DFI. But this happened. So this is another proof, like there are indirect indication of the male factor infertility. You don't always find something in a semen analysis. Most of the time you don't. So second question is, we are anyways doing ICSI in oligosteatosis, what is the need for DFI? So we are living in the age of ICSI, which overcomes many of the natural barriers. You know, we are selecting sperms on our own. When we do IVF, the sperm is selected by God. But when we do ICSI, we are selecting the sperms. We do not know what is inside. We are just looking at the morphology and selecting the sperms. So we can select a sperm with the damaged DNA, where the result will be compromised, obviously. And it will also lead to poor pregnancy rate, increased rate of miscarriage. So only ICSI is not the answer. When the semen parameters are poor, we have all the more reason to do DFI. Now, the third question is, how is DFI assessment useful in planning IUI cycle? See, Bangam et al. Reported that the possibility of pregnancy using IUI was close to 0 if DFI was higher than 30%. But the thing is that we don't do DFI as a routine for everyone. So, when, okay, we do not use it as a routine, but you know, multiple cycles fail. You have a reason to do it. It is measuring DNA damage is beneficial in predicting IUI results ahead of time. And when DNA damage is extensive, ICSI should be considered. So this is a very important tool to counsel your patient that it is high time you switch over to ICSI. Don't just keep on trying IUI cycle, 6 cycle, 8 cycle. This is what we normally see in ROPD. How about RPL? Again, let us understand through this a clinical scenario. This young lady, 32 years old, comes with history of previous to early trimester loss. AMH is 2.98, AFC is 14. One missed abortion at 8 weeks, one chemical pregnancy. Basic investigations are all normal except hypothyroidism. Husband semen analysis, everything normal, everything good. In semen, again, just beyond the viscosity, all the parameters are very good. 2 cc volume, 64 million is the count, 56% motile, 20% rapidly progressive. I very reluctantly ordered DFI, and to my surprise, it was 55%. I just did not do anything, put her on antioxidant and some lifestyle changes, weight reduction, all. She had a spontaneous conception and delivered a healthy baby. So that's the importance of doing DFI for RPL cases. So what is the algorithm for the management of high sperm DFI? It should be checked wherever required. What are the indications? I will discuss in next slide. Correct the correctable conditions, like treat the infection, varicocele, if clinical varicocele, treat it, lifestyle factors, genital infections should be treated. And then, you know, you have to advise your patient to have shorter abstinence. Even if they are trying naturally or IUI, advise them shorter abstinence. If the DFI persists, take them for ICSI. And if the repeated attempts at ICSI fail, counsel them for testicular sperm. Now, let us have a look at the guidelines by Global Andrology Forum, published in April 2025. These are very latest guidelines, and it says that what are the indications of DFI? All men with unexplained or idiopathic infertility based on thorough negative diagnostic workup should be counseled to undergo DNA fragmentation. It is a strong evidence. It should be considered in the workup of RPL, regardless of conventional semen parameter, strong evidence. It should be considered in the workup of varicocele, but is not indicated for subclinical varicocele, strong evidence. It should not be, I mean, it's not very helpful in people with the mild, in the clinical varicocele in the presence of normal semen parameter, that's a weak evidence. Elevated DNA fragmentation can have detrimental impact on ART and associated with the low pregnancy rate after IVF, this is strong evidence. It should be considered when ART is planned for a male factor, especially if there has been a previous failure of ART, again a strong evidence. It is also recommended for the recurrent ART failure, including recurrent fertilization failure, recurrent implantation failure, recurrent pregnancy loss, everything, there's a strong evidence to go for this test. In the setting of ART failure, testing should be offered for men with unexplained or idiopathic infertility, like the case which I discussed. In the men who are 40, go for a DNA fragmentation. Men with risk factor, like smokers, go for DFI. In couple undergoing ART with elevated DFI in the male partner, additional measure to lower SDF may be beneficial in improving ART success rate, again a strong evidence. Now, how about the testing methods? The tunnel, COMET, SCD, SCA, they are all recommended SS for measuring HDF. This is strong evidence. There is no standard cutoff. Now, you will ask me, you did not mention what is the cutoff of HDI. There is no standard cutoff. The lab should be, they should establish their own value. On an average, we take 25-30% as a cutoff, and less than DFI, less than 25 is okay, more than 25 is high DFI, like so on and so forth. There is no need to order a second confirmation test for elevated DFI to confirm the diagnosis, and this is a weak evidence. Now, how do we treat these patients? So, conservative first-line management, there's like lifestyle modification, reduce abstinence, and these are the strong evidence. Weight loss is no smoking, alcohol, treatment of genitourinary infection, elimination of toxic exposure, this is a strong evidence. Antioxidants, now coming to antioxidants. The antioxidant treatment significantly increases spontaneous pregnancy compared to control, this is a weak evidence. And ma'am, we also discussed the same during that lecture about the antioxidant female as well. It's a weak evidence. But antioxidant can be offered to men with high SGF, particularly those with a risk factor known to increase. This is a strong evidence. So the effect of antioxidant treatment on live birth rate and miscarriage rate has been controversial, and this is again a strong evidence. So antioxidants plus minus. There is no consensus in the type, doses, duration of antioxidant for infertile men, and this is again a strong evidence. Now, how about varicocele repair? Varicocele repair may significantly reduce HDF in patients with elevated levels. It's a strong evidence. Varicocele repair should be offered to infertile men with clinical varicocele, but not with the subclinical one. Yes, ma'am, with the elevated DFI. But yes, even after the varicocele surgery, DFI is, the semen parameters are not normal, again the HDF is indicated. Sperm selection techniques, these particular techniques which I just discussed, they can have a role in cases of ART failure. So although they are expensive, that they can be useful. This is a strong evidence. Testicular sperms, they are not a routine recommendation for everyone with a high DFI. But yes, they should be reserved for people where it is indicated, and this again a strong evidence. So to summarize, DFI is an important investigation for male partner. 15% males have high DFI with otherwise normal semen analysis. It helps in predicting results of IUI, also helps in counseling couple to consider ICSI. In case of persistently high DFI, testicular sperm is the treatment of choice. Thank you very much.